thought I would be a victim of a stroke. I never thought this was something that could happen to me. I'm Teddy Bruschi, husband, father, professional football player, and stroke survivor. Through my college and pro career, there's about every injury you can name possibly that I've had, from my ankles all the way to my neck, and from pain levels ranging from 1 all the way to 10. A recovery from an injury that you can control is much more easier to rehabilitate from. When I had a stroke, there were some aspects of my recovery that I had no control of. I lost part of my vision. These are some things that you can't rehabilitate on your own. You just have to hope and pray that the right decisions are made, the right procedures are taken. When I got home those first few weeks after the hospital, I think it was just about healing for me. My energy level was very low. I would get tired just getting up from the couch or walking up the stairs. My fatigue level was very high. Emotionally and physically, I was pretty beat down. Pretty much in my mind, football was out of the question. Getting to the point where I could still run with my kids and still pick them up and still be able to play baseball with them was something I wanted to do. After my first few days at home, a visiting nurse came and saw me, and she helped me with rehabilitation, the basics of walking, of using my arm again, of writing my name again, seeing how my vision was doing. It was very slow at first. The type of exercises my rehabilitation therapist had me do varied from very elementary things to balancing on my left leg. I really didn't think it was possible to come back to play professional football after a stroke, and really, I didn't want to. There was a moment I had in my bedroom when I was asleep, and it was in the middle of the night, and I sat up in my bed and I looked at a clock. With the deficits I had in my eyes, if a clock said maybe 10, 12, I would see 0, 1, 2. I wouldn't see that 1. So at this particular moment, I knew what time it was. It was 12:23. And I'll always remember that time because I could see that 1, I could see that 2. That was really a moment for me when I said, I think I can see again, so maybe this is possible.
If you are a stroke victim, don't give up. Stroke is a medical emergency. It's the second leading cause of death in developed countries. Prompt treatment is crucial. Early action can minimize brain damage and potential complications. The good news is that stroke can be treated and even prevented.
I was 44. It was around 12:30, and I was supposed to go get my son, go to his school and be part of the school party. And I was standing upstairs getting ready for the party, and that's when the stroke occurred. Not knowing what was happening, my right side of the body fell limp, and then I must have passed out. And when I came to, here I was on the floor, and not being able to move the right side of my body, I couldn't get to the phone to call for help, and so I had to wait. And as I waited, my son came home, and he saw me laying on the floor, and he called the doctors, and called an ambulance right away, met me at the house, and took over there. I couldn't believe at age 44 I was having a stroke. I had a slight headache.
For how long you had it before you had the stroke?
I would say I had the headache about an hour beforehand.
An hour. Do you regret that you didn't seek help at the right time, probably with that headache?
Yeah.
Okay.
If you or a loved one is experiencing stroke symptoms, seek immediate help at a specialized center instead of becoming a victim of stroke.
Today it's my pleasure to welcome to you Dr. Webham. He is the director of stroke program in Mercy St. Vincent Medical Center, and also the endovascular neurosurgery program, which was started recently in St. Vincent. It's my pleasure to welcome you.
Thank you very much.
So today we are going to discuss few elements about stroke treatment, and I want to emphasize how important to the patients that if any one of them or any family member having signs of stroke, where they should go.
One of the current controversies in stroke medicine revolves around the point of care for patients suffering from ischemic stroke symptoms. And so traditionally, folks that have stroke-like symptoms were told to present to their nearest, closest emergency room. Much of that was before the availability of neurointerventional treatments and comprehensive stroke centers that exist today. And today the game has changed somewhat in that when people have stroke-like symptoms, they may be, in fact, better served presenting to a comprehensive cerebrovascular center capable of doing everything from basic medical emergency management, complex imaging, neuroimaging, and also selection of the correct patients for neurointerventional procedures. And our program is an example of one of those. And so for modern stroke patients that present with stroke-like symptoms, the game has changed somewhat in allowing them to pick from an option of comprehensive stroke centers to allow the full spectrum of care to be delivered for whatever the eventuality. It would be the cerebrovascular corollary to somebody with angina presenting to a center without the full scope of cardiac intervention in the world of cardiology today.
So what you are suggesting basically is to treat the stroke like the heart attack. So let's call it a brain attack. That they should go to the centers which is equipped and ready to treat those. The way we treat patient with myocardial infarction within short period of time, which could be about 30 to 90 minutes, we have to intervene, we have to finish the angiogram, and we have to make a decision about the treatment plan. And this center is one of those centers available at this point in Northwest Ohio.
Exactly, and in fact, the time frame in cerebrovascular illness becomes as important, if not more important, in cardiac work because it's such an unforgiving disease process, and the pathology and the physiology is so much less forgiving than even the cardiac windows that, in fact, we have patterned historically a lot of our triage of patients, emergent imaging, and then comprehensive assessment and procedures based on the cardiac world and the lessons we've learned in the 70s and 80s in cardiology. And so today our focus is on time, and we often say that time is brain. And our goal is to get patients in, assessed, and get them the full spectrum of care in a time frame that's physiologically important with this kind of disease process going on.
And that brings us really for some of the satellite hospitals, like, you know, if someone having stroke, everybody is panicking, rushing into the nearest emergency room. Probably what we want to give the message to the patient that if they advise them to be transferred to a more equipped and more advanced center, not to be surprised. That's to their advantage. Is that the case?
In many ways it is. In fact, you know, we know for a fact that a statistical number of folks that have ischemic stroke symptoms will go on to need either advanced imaging or interventional care, or endovascular or minimally invasive care for their stroke. And so in many circumstances that puts them at an advantage if they're already at a center where the full spectrum of care can be delivered.
If we go right now, that patient arrived into the emergency room and we're going to treat him as a brain attack, like a heart attack. What are the steps which is that patient is usually going through based on the criteria or the protocol right now you have as an advanced center to treat those patients?
And these days we have a lot more evidence-based medicine to go by, so we take our cues, of course, from the American Stroke Association, American Academy of Neurology, and the Neurocritical Care Society. And very much like the cardiac spectrum of care, our care begins actually in the field, and we try every day harder to push that emergency first-line care back into the EMS vehicles, the ER level of entry of the patient, and really provide aggressive physiologic assessment and medical management on the way through a secondary step, which is typically neuroimaging to select who's most at risk for what procedures and who can benefit from what procedures. A lot of that new comprehensive neuroimaging is done. Patients are selected for the appropriate next step medically or surgically based on those initial images generated, and then it's often very easy to bring those patients directly into an interventionally equipped lab like the one you see here for advanced procedures if they need it, and then in context with a dedicated neuro ICU and supportive rehab facilities that allow the patients to get the most out of the spectrum of their care that they can get and get as better as they can get from the disease process that originally brought them in.
As women, we do it all, at home, at work, and in our communities. But we can't get so busy that we forget ourselves.
Donna, women are so busy these days. How can we work exercise into our schedules?
Start small, take the stairs when you can, park your car further away when you shop, take a walk over your lunch break, and do some jumping jacks during commercials on TV. Believe me, it adds up to a healthier you.
We're just like you. ForEveryWomanByMercy.org.
Now, I want to emphasize that the people who are in charge of that kind of program are specialized professional people. It's not like any neurologist or any radiologist. They are specifically trained to treat these kind of problems. Am I right?
Yeah, like the adage goes, it really does take a village. We have a group of specialists that range from EMS folks in the field and helicopter pilots and complex emergency care that goes on at the entry level in the emergency room, all through the folks that do the neuroimaging and specialized neurovascular assessments, comprehensive stroke neurologists, rehab specialists, dedicated neuro response nurses, and neuro ICU for these types of pathologies. That really distinguishes a program like this from a conventional hospital that's not got the full spectrum of care to deliver.
Sure. We need to give the patient, the general public enough information about types of stroke. Can you give us a summary of that?
Sure. Stroke is broadly categorized in two broad distinctions, that being ischemic stroke, or stroke as a result of a vascular occlusion or a lack of blood flow from a plug vessel, versus hemorrhagic stroke, which usually means a rupture or a leak of a series of vessels in the brain that allows blood not to get to where it needs to get. The end result of both ends up being brain deprived of blood and oxygen, much like the heart in a cardiac scenario. And so those are the broad distinctions. We know statistically that somewhere in the average of 700 to 800,000 strokes a year occur in America. Current statistics point out the fact that about 1 million neurons per minute die in an ischemic stroke, and folks that suffer hemorrhages or leaks from things like aneurysms or AVMs, many of those, almost 50% of those folks are potentially at risk for a lethal injury before they even make it to the hospital. The other 50% that make it in, almost half of those folks go on to have permanent disability. And so it's a very significant group of health pathologies that faces patients.
We have to mention that stroke is considered like the third common cause of death in the United States. It's so important to address it and immediately rush into the emergency room, and that's what really we are trying to talk about, to save life, to save also some kind of injuries coming out of from the stroke. Now, in the past, we used to talk about if we have a stroke, the most important thing is to get to the emergency room so that we can give them what we call a lytic treatment, try to dissolve those clots, assuming that it's ischemic stroke. Is that the only option we still have? Or right now with the advanced technology, and that's why we have centers as big as this one, there's much more can be done?
In fact, that's true. Quite a bit more is able to be brought to bear on stroke than ever before, I think, today. The gold standard has typically been to assess folks in a window of about 3 hours or under, and bring those folks to IV lytic therapy with peripherally inserted IVs that deliver clot-busting medication, or IV TPA, to the whole body and thus the cerebral vessels in the head. Some literature has come out in the last couple of years that has extended that window up to 4 to 4.5 hours under the right circumstances and with proper neuroimaging. In addition, we have literature that indicates that we can do more with intraarterial or IA TPA when and where that's warranted, as well as mechanical embolectomy or mechanical clot extractions that actually go on in an interventional lab like this for folks that even are out in windows of 6, 8 hours or 12 hours or more for the right physiologic circumstances. But again, key in that is patient selection for safety of the right people to revascularize and which people are not the right people to revascularize. And that's part of what makes a comprehensive center with all its working parts such a powerful thing to bring to bear on stroke today.
And that really is so important that they extended the time to 4.5 hours, really, that give the people who are in the far distant area from like Tiffin, Defiance, anywhere really close to this hospital, that they still have time, even that they arrive to the emergency room immediately, to discuss with that emergency room how important to be moved to a center like this center, so that treatment will be done appropriately by the professional people, trained people, to save those patients.
Today we have a patient in her mid-50s. Shortly after awakening, she discovered left-sided weakness and numbness. She's within 3 hours of the beginning of her stroke symptoms. A head CT does not yet show damage, nor is there bleeding within the brain. There's a good chance she may be helped with the clot-busting medicine TPA. She was given the medicine, but unfortunately it did not cure her stroke. Quickly, we performed a CT angiogram to help identify the blocked artery. The blocked blood vessel is too small to clearly see. We need a better test. A CT perfusion scan clearly shows an area of brain that is not getting sufficient blood flow. Green means the brain tissue is still alive and may be helped by restoring blood flow. I started an emergency angiogram, entering her arterial system at her left groin. I passed a catheter, a small plastic tube, from her femoral artery up the aorta and into her right internal carotid artery. These are the arteries of the right side of her brain. We are looking for a vessel that flows slowly or stops prematurely due to a clot. Looking closely, we can see that there is a medium-sized branch that does not flow properly. Now, magnified, we can see that the blood flow stops here, To illustrate, let's look at the middle cerebral artery of another patient. I highlighted the blocked branch that we need to open in our stroke patient to help her symptoms of numbness and weakness. To open the branch, we're going to use a penumbra aspiration catheter. Through it, I will pass a separator that will break up the clot. The catheter is connected to suction to pull away pieces of the clot. The tip of the separator is very soft and doesn't traumatize the vessel. Let's look at the penumbra system in a flow model. Once the catheter engages the clot, it can quickly clear the vessel. To the left, you see what the catheter and separator look like under X-ray. While the clot may not show up under X-ray, our images tell us where we need to work. I have advanced the aspiration catheter into the affected branch. Now, moving the separator back and forth across the clot, we can try to break up the clot and carry pieces away with suction. I will inject some contrast to see if the vessel is opened up. Now we are starting to get some flow through the branch. I will make several more passes back and forth across the clot. Our goal is to clear as much of the clot as we safely can, if possible, fully restoring flow. Now the vessel is flowing much better, maximizing her chances for a recovery.
New medicines, new procedures. The more complicated healthcare gets, the more you need a special kind of expert at your side. Sure, Mercy physicians are leaders in using the newest medical technology, but something just as important never changes. A commitment to listening, to understanding, to finding the best option for you. The choice to be in expert caring hands? Choose a Mercy physician. Find yours at mercyweb.org/doctors.
What about hemorrhagic, the bleeding stroke? I mean, that's another common problem. We see it sometimes. So what is the newest treatment or management at this point?
Current therapy as well for hemorrhagic stroke encompasses a variety of specialists and different techniques. Traditionally, folks that come in with ruptured aneurysms or AVMs or intravascular malformations in the brain have been traditional surgical candidates. In the last 10 or 12 years or so, more and more is being done minimally invasively for that. And a good portion, perhaps 80–85% of ruptured aneurysms or other vascular abnormalities in the head today can be treated minimally invasively in context with a global neurosurgical assessment of the patient to give people an additional tool in the arsenal to treat intracranial vascular ruptures. Probably by far the most common is an aneurysmal rupture or AVM rupture. We see a good variety of those each year. Again, that's another entity where time is brain, and so for a lot of those people that rupture a vessel, they have rises in the intracranial pressure as a result of extra fluid being in the head, which is a closed space. And even if the initial injury of the ruptured vessel doesn't hurt them or kill them, the precipitous rise in pressure in the head without traditional neurosurgical assessment and evaluation and treatment can very often take the patient's life. So again, that's another important facet to being in the right place at the right time with a broad scope of care like St. Vincent's. What is the percentage of the patients who comes with, ischemic stroke versus hemorrhagic stroke in general? We roughly estimate in general perhaps anywhere between 80–85% are going to fall into the ischemic category. Another 15–20% may fall into the hemorrhagic category, small subcomponent of which is subarachnoid hemorrhage from aneurysmal disease like AVM or stroke,
and that,
or AVM or aneurysm rupture.
That make it so important that the ischemic one, the one which is having a clot or a blockage, they could be saved much faster by having the appropriate treatment. Comparing to the hemorrhagic, probably the outcome a little bit not as perfect as the thrombotic events. Right.
With all of these entities, of course, we know more and more these days that time is really the enemy more so than the actual disease process. And one of the goals globally in the world and in the United States is to get the care faster to people with these time-sensitive illness, very much like the model system we've built in America for cardiology and some of the advanced salvage and rescue there. And I think that encompasses a number of things. One, very early recognition of stroke-like symptoms, be they ischemic or hemorrhagic, at the primary level of point of entry of the patient into the medical system. And then also self-education of patients to know what are my risk factors for stroke or hemorrhagic stroke, and what are my potentially modifiable risk factors for those diseases, and what are the signs and symptoms, and how can I recognize those, and where should I go, in reference to your first point, when I have those symptoms, and what's my best chance when I have those symptoms.
Now, to have a successful program, I always emphasize on how important the team, and this is really what I want to emphasize, that probably if you give us an idea about the team you work with, it's not only you are as a specialist and you do the procedure and it's done. Actually, post-procedure care and recovery is going to be probably as important as the procedure itself which you do. So can you give us a detail about how equipped and how trained the team which you are working with at this point?
Absolutely, yeah, I can't echo that sentiment enough. It is a team sport, definitely what we do, and it encompasses a number of specialists that span the spectrum, again, from emergency medical management all the way through the medical cascade to folks that do complex imaging in real time, complex supervision and maintenance of equipment to do the kinds of procedures you see behind us, to a very comprehensive neuro ICU manned with folks that treat this entity only and are very used to the physiology and behavior of these patients and some of the risks and pitfalls. In addition, a strong emergency room presence and really accurate assessment of folks is key, and stroke neurologists that work in concert with the general neurologist and general neurosurgery presence in a hospital make for a team approach to these disease entities. And very often, as you said, these patients have other medical problems. We know for a fact that a lot of the physiology of stroke and cardiac disease is very keenly linked. And so folks that present, say, with a hemorrhage or with a stroke very often suffer cardiac challenges as well. They can go on to have dietary, rehab needs, nutritional needs, complex assessment for physical therapy or occupational therapy, or even rehab placement and rehabilitation. So one of the goals when the Joint Commission looks at stroke centers and comprehensive care is to make sure each of these key elements is there and working in concert and brought to bear on these illnesses, which I think is the future of stroke neurology.
So if we will want that patient not to be our patient, I mean, we want them to be safe, we want to prevent them from having stroke. What are the major risk factors for developing stroke? I'm sure it's like the heart, probably there's some criteria which you follow.
In fact, they very closely mimic our cardiac risk factors, and they of course are other associated comorbidities like diabetes, hyperlipidemia, obesity, things that are modifiable risk factors. We also know as well, both for hemorrhage and ischemic stroke, there are some linked genetic components as well that put people at risk. There are certain racial and ethnic statistical predominances in certain groups based on genetics that we know of today. Small variety of folks, especially younger strokes, fall into a particular category that's keenly linked to your specialty, which is cardioembolic etiology, where folks are the victim of a stroke because of a cardiac reason. And so a lot of those are very, in fact, correctable, and if identified early with TIAs or stroke-like symptoms, can be corrected by a good cardiologist before they result in a stroke. And I think there's a lot of risk factors that folks can modify. When you think of stroke, you kind of don't think of modifiable risk factors, but in fact there are many, very much like cardiac disease or other vascular diseases, and they fall in line with that. And part of that is recognizing your family history and recognizing some of the genetic predispositions, understanding what are modifiable risk factors and what are not, and then trying to do something about them the same as you would for your cardiac profile.
Sure. I want to emphasize on the high blood pressure or hypertension. I mean, how important when it comes to stroke. You know, we have too many patients always when you see them in the office, oh, I have a white coat syndrome, and their blood pressure like right. 200 over 110, and that stick in the mind. I just want you to explain to the patients that how significant that minimally higher blood pressure than it should be could lead to a major devastating
sure.
stroke.
And that's one of the key elements, is hypertensive control long-term in someone's life and lifestyle is again, another one of those modifiable risk factors that's very keenly linked, particularly to hemorrhagic stroke, but also to ischemic stroke. And there are current guidelines that suggest what are the best ranges of blood pressures to keep folks in for both of those entities. And that's again a risk factor that does damage chronically to the lining of blood vessels and weakens them and can put people at risk for either anything between a dissection or a hemorrhagic stroke or an ischemic stroke based on continued injury to those linings of the blood vessel. The same is true for cardiac disease. So it's among the more predominant modifiable risk factors as well for cerebrovascular illness. One of the things we've noted, we looked at the demographic statistics for the area, is that we suffer at a younger age in the Toledo market from strokes than we're used to seeing nationally, and I think that puts us in a good position to try to do a lot more early modifiable risk factor intervention. These are folks we can catch before they do 25 years of damage to blood vessels in the neck, head, or heart from things that are modifiable. In addition, the lab that is currently under construction and about to conclude its construction will be one of the more advanced labs in this whole half of the country and actually offer some techniques and imaging that are not offered anywhere else in this market and region.
It's so important. If you remember when we started this program, our goal is to introduce to the community all of the advanced technology in this area. We should be proud in our town that we have a program and a center like that who is providing that kind of services.
The future of stroke treatments includes telemedicine, coming to Mercy St. Vincent soon. Telemedicine at Mercy St. Vincent will allow patients in distant areas to be immediately evaluated by neuro experts to make the appropriate and fast decisions for the best treatment plan for those patients. Let's learn about telemedicine.
When a patient in a remote rural area experiences an acute ischemic stroke, they are quickly transported to the nearest hospital. This spoke site is equipped with a CT scanner and has the ability to administer care, but there are no neurological specialists on staff at this remote location. The attending physician in the emergency room performs a clinical assessment of the patient, which is consistent with a diagnosis of acute stroke, and orders a CT scan of the patient's head. While the patient is being scanned, the attending physician calls a stroke code and initiates a consult call with the critical care center at the hub of the telestroke network. The on-call stroke specialist at the hub institution is able to take the call from the remote center, wherever they are, and are able to review all of the patient's imaging results immediately after they are acquired. In combination with the clinical information gathered during the clinical consult, the stroke specialist recommends that the patient is an ideal candidate for thrombolytic treatment. The spoke site administers thrombolytics to dissolve the occlusion and restore blood flow to the ischemic region. Having anytime access to neurology expertise, coupled with the local access to acute treatment, provides more rapid delivery of care, resulting in better outcomes and reduced long-term healthcare costs.